I think we are.
Professor Giorgio.
Okay, thank you. Well, hi everybody, good morning. Thank you for being here to this Ágora seminar. Today we have Simon Turner from the School of Management who is going to introduce us to a study where they look at how different narratives sparked by the COVID pandemic are leading to different types of changes in the Colombian health system. Simon joined the School of Management from the University of Manchester, where he was a senior lecturer in health policy and organization. He has over 14 years of postdoctoral research experience, having held different research positions at University College London, King's College London, London School of Hygiene and Tropical Medicine, and the University of Cambridge. He holds a PhD in economic geography from the University of Durham and undergraduate and master degrees in human geography from the University of Birmingham. He is an honorary research associate, Centre for Business Research, University of Cambridge, and fellow of the UK Higher Education Academy. Simon's research interests lie in applying social sciences, theory and methods, particularly ethnography, to the study of organizational and innovation processes in healthcare and wider public management. His research has been published in different leading international academic journals. Simon, it's a great pleasure for us to have you here. Thank you for accepting our invitation. And we are really looking forward to your talk that is, of course, very important in the current situation. So please, the microphone is all yours. You have 40 minutes for your talk.
All right. Thank you very much, Giorgio, and to Daniel for organizing the seminar program, and to everyone for joining us today. I should just thank at the beginning Uniandes for funding our qualitative study of health system responses to COVID-19, the participants from the Colombian health system who gave up their precious time at a very difficult time for health services to help us, the School of Management Research Office, and the dedicated research team who are listed here on the slide. So this has been very much a group piece of work. So Natalia, Anna Maria, Vivian, Carolina, Natalia Botero, Monica, and Juan Pablo have all been fantastic in terms of our study. So today I'm going to introduce the overall research that I worked on with the team, then present some more specific findings on resilience among health system leaders. So when we applied to Uniandes for funding about a year ago, we looked at the emerging management literature on COVID-19 and found a hypothesis based on East Asian economies' experiences. It was that health system integration, so positive relationships between different actors and organizations, supported adaptation in response to environmental shocks like COVID-19. We wanted to study this hypothesis in Colombia, how our health system responses within major cities like Bogota, Cali, and Cartagena being coordinated here. So our 10-month study from May 2020 till March 2021 had 4 objectives at the top of the screen here. So to identify the organizational strategies used to respond to COVID-19, examine both barriers and facilitators to collaboration between actors, and to identify stakeholder preferences for sharing our findings. So over the 10-month period, we conducted 118 interviews with healthcare providers, national and local level planners, professional associations, and insurance companies, among others. Conceptually, previous research that both I and others conducted before the pandemic identified some simple rules for guiding major system change where multiple providers and planners are involved. For example, centralizing acute stroke services across large metropolitan areas like London and Greater Manchester, the equivalent in size of Bogota or Cali. Such coordinated change, to which various health system stakeholders need to agree, is understood as a social process. It requires learning from past change attempts, leadership to align multiple stakeholder interests, and clinical and public engagement. However, these rules were very much derived from research on longer-term planning of service change. Centralising stroke services in England took many years to accomplish. We wanted to know how rapid change works in response to a crisis like COVID-19. What are the barriers? What are the facilitators to coordinating change in this context? So based on our findings in relation to COVID, we developed 6 new rules for guiding health system adaptation in response to both COVID and future pandemics. So these are on the screen. These are to make time to evaluate changes to services, acknowledge the need for trial and error learning, support networks of expertise, safeguard the workforce, combine soft and hard coordination mechanisms, and invest in intersectoral relationships so that these can be mobilized rapidly when crisis hits. So I'm just going to talk through the first rule. So the first rule is to make time for evaluating accelerated innovations. This rule is based on an international systematic review that we conducted with the help of final year undergraduate students in the School of Management. It's just been accepted for publication in Implementation Science. So it's forthcoming in that journal. The source is on the bottom of the screen there. So from the 34 qualitative studies reviewed, we identified a range of organizational changes in response to the pandemic, expanding use of telemedicine, organizational strategies for prioritizing particular types of evidence on COVID-19, and visible leadership to improve morale on the front line among the workforce. The review indicated that service change in response to COVID-19 has been characterized by the pace of adaptation, a particular burden for local system level actors in coordinating responses, and also an impact on frontline staff from undertaking new roles and responsibilities in helping health systems to adapt. Due to the accelerated nature of service changes made over the past year, we recommend making time for evaluation. To give just one example, have patients and doctors' preferences and experiences of telemedicine services being evaluated. So today, I'm not going to describe the other rules in detail because we gave an earlier webinar in March if you're interested, that's on our Twitter feed. And we've got an example here of the guidance that came out of our study, which is very much aimed at health system leaders. So this is just a screenshot from this interactive PDF, which has videos, examples, and further resources from our study, which is available on our website. And the link, I think, should be in the chat if you're interested. So this is the home screen for the guidance, and we've got the various rules that you can click on the right-hand side. This is just an example of one of our 5 rules. So the idea of combining soft and hard coordination mechanisms. And I think before I carry on and switch focus, I'm just going to play one of the videos from this rule of combining hard and soft coordination mechanisms. And it's just 2 minutes long. So hopefully you can hear this.
Relaciones interorganizacionales. Nuestro estudio identificó los mecanismos de cambio que mediaron en las relaciones interorganizacionales entre secretarías de salud y aseguradores, como las entidades promotoras de salud, EPS, e instituciones prestadoras de salud, laboratorios clínicos y hospitales, y su importancia para hacer posible la vigilancia coordinada del COVID-19. También identificó la prestación de otros servicios de salud en respuesta a la emergencia. Algunas funciones de vigilancia incluyen toma de pruebas diagnósticas a nivel domiciliario, independientemente de la afiliación y aseguramiento de cada individuo. Identificación temprana y activa de casos a nivel comunitario. Establecimiento de cercos epidemiológicos. Ejemplos de acuerdos contractuales formales que apoyaron la coordinación entre los actores del sistema de salud fueron las estrategias denominadas Acuerdos Tripartita en Bogotá y Cali y Cuidémonos Cartagena en Cartagena. Dentro de los mecanismos de cambio encontrados que mediaron y facilitaron el desarrollo de estas estrategias están los cambios administrativos y regulatorios que promueven la colaboración, la formalización de las relaciones que incluyen liderazgo a nivel nacional y local, confianza y fe en la colaboración, percepción del éxito mutuo, intercambio de información, balance de poder, compartir recursos.
Okay, so hopefully that gives you a quick flavor of the kind of resources that are on the guidance, and there's some other videos on there. This is just the final page on the screen from the guidance, which is a checklist for reviewing the rules from our study. So if you're interested more, feel free to visit the website. I'm very happy to hear from anyone who's got links to health systems and wants to talk further about the guidance. Okay, but I'm gonna shift focus now, and I have a question for you, which is, how has the pandemic affected your work? And I think we're just gonna kind of try to build a quick word cloud together, and I'm adding the link here again to the chat, which should take you to the Menti page. Otherwise you can use the menti.com and add in the code. I'm just going to add the link again to the Menti link there. And just in 3 words, how has the pandemic affected your work? And if we can try and maybe build a word cloud together. And I just want to get a sense of how people here feel they've been affected over the past year by the pandemic.
Where do we answer?
Sorry, Eduardo. So you can go to, there's a link in the chat, menti.com. Okay. That should take you straight to this particular poll.
All right. Thank you.
Hopefully.
Thank you.
Okay, no worries. So just 3 words that come to mind when thinking about your work over the past year. Okay, so yeah. So we've got some, I guess we've got some positive words in there. Like learning can be seen as positive, more productive. But a lot of them are quite kind of challenging words as well, I think. So more work, stress, overwork, less interaction, struggling to keep up with the changes. But I think there's a sense that a lot of those words are quite challenging ones for us as a faculty. So I'm gonna kind of explain this question a bit more with the next slide. So thank you very much for participating. That's really good to get your feedback, and I can see a lot of you are contributing to that. And someone mentioned emotions as well, emotional overflow as well. Okay, so what I actually want to focus on now is actually a sub-study from our main study, which I actually kind of worked on over the last week or so, which is called "We're All Vulnerable, We're All Fragile," which comes from one of our interviewees, and COVID-19 as opportunity or constraint on health service resilience in Colombia. I'd very much like to get your kind of feedback on some of the data presented today. So the main kind of question behind this is, what were the impacts on and sources of resilience among health system leaders in Colombia associated with responding to COVID-19. So this particular paper is based on 32 national level interviews that come from that broader set of interviews of 118 from the wider study. Okay, so I'm just going to kind of talk about, I guess, one narrative that kind of comes out of the management literature. There's clearly a lot of commentary and evidence which has talked about the very difficult effects of COVID-19. It's been absolutely devastating for health systems internationally and for societies, and we're still living in it at the moment. But there is one managerial narrative that talks about COVID-19 being potentially a source of learning and innovation, particularly for health systems. So there's a couple of papers here that talk about COVID-19 being described as giving permission or being a catalyst for health system improvement. And if you don't know a lot about health systems, that they're traditionally seen as not particularly receptive contexts. You've got a lot of professional power, which tends to inhibit innovation and change. So to some extent, having a pandemic can potentially support people in actually driving forward change. There's a second area of literature on resilience, particularly resilient public services, which are adaptive, sustainable, transformational. Even some of this thinking suggests that environmental shocks, such as a pandemic, may actually allow resilient health systems to assimilate new capabilities as they learn in response to a particular shock. But when you look back at some of the earlier literature that I'm fairly familiar with, particularly on diffusion of innovations, and there's a systematic review here from 2004 from Greenhalgh in health systems. When you look at this literature, it suggests perhaps opposing or countervailing forces around COVID-19. So at the individual level, we might see receptivity to change by particular adopters because there's a clear case for change on the one hand, there's a clear need for change on the one hand. But on the other hand, there's also a lack of evaluative evidence. And if you want someone to adopt an innovation, you have to present a very strong case for change and say, well, this is the particular path we need to go down. This is why we need to adopt this particular innovation. And I've looked a lot at the role of evidence in decision making. It's pretty important. And in this particular context, we don't have a great deal of evidence to convince individuals to change. And similarly, in this literature at the system level, there's also a tension here. Well, not a tension, there's also some opposition here between, on the one hand, attention or pressure for change that again comes from the obvious effects of the pandemic, but at the same time, a lack of slack resources within health systems. I think these have been very quickly consumed by responding to the pandemic. And normally, if you want to innovate, you need slack resources for experimentation. So we've got a mixed picture here around diffusion of innovation. So the argument, I guess, of this paper, and we might kind of talk about the different labels here and potentially some additional labels as well, is that there have been 5 kind of mixed heterogeneous effects on health system leaders among those we talked to. So based on our thematic analysis, we see that firstly, COVID-19 acted as a mirror for recognizing problems that predated the pandemic, potentially exacerbating some of those as well. It was also an accelerator of changes to services, particularly actually around telemedicine is very prominent. It was also a source of solidarity or common purpose among professional groups. And I want to dwell on this a little bit. It's also from our interviews, this sense of trauma on the workforce, generating fear, uncertainty, very much greater workloads, which comes out, I think, in the word cloud that we just worked on together. And then finally, it was disruptive, I guess in the negative sense, not in the Schumpeterian sense, but of adjacent and pre-existing improvement activity. So I'm just going to kind of work through these 5 themes, and I want to really just present to you some of our kind of interview quotes, so you can get a bit of a feel for our data. I'm just going to have a sip of coffee. So the first theme is this idea of being a mirror for recognizing existing problems, and indeed based on that, providing some suggestions for how health systems should change in the future. And one of the clear kind of themes that comes out both in work in Colombia, but also our systematic review of international studies, is that working conditions have very much been brought into sharper focus. And the interviewee says here, even before the pandemic, we are broken. The doctors in the country were in a very bad psychological condition. And this is reflected in the number of suicides that we see, in the amount of depression that is seen. And if that was before the pandemic, how will it be now? And that is one of the things that we have told the government. And I was very clear, both with municipalities, hello, please make psychological support programs for those people who are going to face the war every day and with a fear of falling into that war. So very difficult circumstances, I think, from this interviewee's perspective going into the pandemic, and then potentially exacerbated by it. We also sort of saw in the interviews this idea of an entrenched culture of blame within the health system as well, at the inter-organizational level, but actually different levels within the health system. And we might kind of think about some of the structural reasons that might contribute to this culture of blame around promoting competition, arm's length relationships, and so on within the health system. But this interviewee says here, it is not easy because there are generations and generations looking for where the culprit is. Look at the health system. The health system is always looking for culprits. This should have been made by the insurance company. This should have been made by the healthcare provider. The doctor is the one who should have done that. That was the state's responsibility. So a kind of culture of blame that has been highlighted by the pandemic. The second theme is this idea of COVID-19 being an accelerator. I think this could potentially be seen as a more positive effect of the pandemic. But we saw in our interviews in particular, people highlighting the expansion of telemedicine services. And this is, again, this has been borne out by international reviews as well. It's not just a Colombia issue, it's happened internationally. And this national insurer talks about how this has really been scaled up in response to the pandemic. So this interviewee says, we had a few beginnings in telemedicine, but it was precisely the pandemic that forced us to make some dramatic changes in the preparation of resources and the purchase of technology. And in record time, we've been able to make changes that are now working properly for this type of care. We also, I think, had some more critical perspectives as well on the expansion of telemedicine. One is around actually kind of evaluating its appropriateness and acceptability to the population of Colombia. So very rapid service change, but this representative here questions its relevance to many people within Colombia. So they say, it turns out that more than 20 million Colombians do not have digital connectivity, they did not have broadband. How are you going to talk about teleconsultation? Well, how are you going to talk about teleconsultation if you have a serious problem of access to electricity in many areas of the country? How are we going to install the computer, the screen for people to make the appointment, and the other one to read the unified medical history? So very much kind of acknowledging the expansion of this particular service, how quickly it's happened, but also questioning perhaps its applicability to the wider population of Colombia. Okay, so the third kind of label or theme I wanted to work on is solidarity, and this idea that the pandemic provoked, if you like, a common purpose or the same frame of mind. Both of those terms were used by our interviewees. And then in turn, this sense of common purpose influenced the people that we spoke to, their willingness to collaborate. So members of professional groups were sharing information as emerging evidence appeared. They were championing common causes like doctors and nurses' interests. They talked about the strengthening of relationships within their particular professions and potentially addressing professional hierarchies as well. So this is the quotation that we drew on for the title of the paper. So this representative talks again about some of the challenges in the health system, but how the pandemic helped to address those. So the problems, the clashes, the egos, the discrimination within the world of healthcare workers is brutal, it's tremendous. The categories, the hierarchies, the doctor is not the same as the nurse, much less the assistant. And I think that condition of COVID, of the current state, has been very beautiful, because I think that everyone has put the pandemic on a level of common humanity. We're all vulnerable, we are all fragile. And again, I'm sure you're aware this isn't just a Colombian issue. This is kind of gone on internationally, as many health systems and societies have come together to face the pandemic. I want to talk now about a bit more of a kind of critical perspective on the pandemic, which is this idea of trauma on the workforce, including health system leaders, not just the frontline workers who've kind of borne the brunt of responding to COVID with new roles, responsibilities. So it's placed, I think, a great burden on health system leaders and workers. It's generated fear and uncertainty, physical and emotional stress, and indeed, particularly for health system leaders, a greater volume and intensity of work. So here we've got an example of that growing intensity of communication. So the quotation here, this person was leading a board. There's been a super informal and not very deliberate increase in communication. Why? Because of that silly little change. Let's not meet every month, but let's meet every day within a pandemic. Now, for me, it has been a torture, because imagine what it is like to have a board of directors every day, but it is a torture that I put up with. So just kind of giving a sense there of that greater intensity volume of work that's kind of been provoked by this need, I think, to coordinate responses to adapt to the challenges posed by COVID. We've got another example here that actually relates to webinars a little bit, but just trying to convey that emotional and physical exhaustion that we heard from a number of leaders of health services. So this interviewee says, from an internal and professional point of view, I also think that people are exhausted, both physically and obviously emotionally. There are many signs that suggest that people are already saying, look, we're kind of exhausted. We launched the first webinars in April of last year, and the number of people was impressive. But you hold a webinar today and you don't manage to get more than 50 to 60 people to come. And just this is the final slide on trauma. We also learned a little bit through the interviews about the ways in which leaders reported engaging in formal self-care, from isolation through to exercise, kind of building this into their day in order to cope with the intensity and volume of work. So the first interviewee here talks about, I isolate myself a little bit at the time from many people I know, because I knew that a phone call was coming to find out something that it was up to the minister to inform. And then the second interviewee talks about bringing exercise into their working day, or some kind of relief from the volume of work, saying, then it's my turn to breathe, to go out here on the terrace, to do yoga for 10 minutes, which I don't do and I don't know how to do, but I kind of try at least to do it. So just a couple of examples there of these kind of informal responses in terms of coping with work in a pandemic. And then the last of our themes, our labels, if you like, is this idea of disruptor of adjacent improvement activity. So COVID-19, I think, was disruptive to some existing ongoing improvement programs, and indeed to some services for non-COVID-19 patients. So we've got an example here of one program concerning the legal regulation of doctors that have recently passed their training, which was cast into uncertainty as planning in the response to the pandemic was prioritized. This interviewee says, well, the pandemic has been catastrophic in all senses of the word, because we just this year, we had very important work that we were developing on the implementation of the law of medical residencies. We'd obtained the budget to start this year. We had the tasks for this year punctually. Then the pandemic falls. Then there begin to be doubts about whether indeed that budget will be available. So I just got, I think, a summary here of those 5 kind of labels or themes. So as a mirror, I think our kind of evidence shows that working conditions very much need to be bolstered. There's a need for mental health support, and that's underlined as well by our international review. It's very much highlighted as a mirror, pre-existing barriers to improving collaboration. So structural barriers, so competition between different entities within the health system, arm's length relationships as well. And in many ways, that then has contributed to potentially a difficult culture, one of blame, according to some of our interviewees. But also, it's been an accelerator. I think there's evaluation needed of those accelerated changes, though, in terms of their appropriateness and effectiveness, particularly around telemedicine. In some ways, I think the relaxation of regulation temporarily has been seen as a facilitator for enabling service change, but I think regulation needs to catch up now. And again, that's something we found in our international review, not just in Colombia. In terms of kind of positive solidarity, it provoked common purpose or frame of mind. This wasn't, though, a universal response. I think there was some indifference as well that some of the interviewees mentioned, and it very much intensified communication across professional groups and hierarchies. In terms of trauma, I think the intensity of work and communication impacted on well-being, and we saw some examples of informal self-care routines as protective measures from some of the health system leaders that we spoke to. And then as a disruptor, it was very much disruptive to some existing improvement programs, and there is a need to focus on all services affected by COVID-19 directly and indirectly. And I think in the future, around mental health linked to the pandemic and the trauma of it is going to be a very important issue for a number of years in the future. So just to kind of wrap things up, I guess returning to that question about that innovation narrative and what does this all mean? What do those effects all mean? I suppose the kind of normative conclusion is that if we wanted COVID-19 to be a catalyst for sustained improvement, I think we do need to do a system-wide collective audit of what practices have emerged in response to the pandemic, and a realist analysis that asks questions like what works, for whom. So it's very much a collective audit. We need to speak to different stakeholders, patients and the public as well, and at what cost, and cost in terms of impact, not just economic cost. But I think there are a number of challenges around calling COVID-19 a catalyst for improvement. I think as a mirror, those kind of old structural cultural problems in health services have not gone away, and some issues have been exacerbated, I think, by the pandemic. So working conditions is very an important issue within the health system. Mental and physical health, safeguarding the workforce is really, really important. And as the pandemic goes on, I think in terms of resilience of health services, safeguarding the workforce is absolutely critical. In terms of resilience, I think it's important to talk about the need for resilient contexts and how we don't just rely on individuals and leaders, but we think about how do organizations, how do systems support resilience. And I think there's very much an interplay between personal and organizational sources of resilience. So for example, if organizational resilience is weak, this would then place heavier reliance on personal resilience, such as health system leaders. And how sustainable or indeed ethical is it that those leaders are kind of put under that pressure? How can organizations, how can systems support them? And then finally, I wasn't really sure what to call this, but there's something around coordination costs as well. So this idea of changing course or adapting in response to COVID-19, the burden of that, I think, very much fell on the workforce, including many kind of invisible frontline workers. And also because of this need to coordinate all these different actors, it relied on very intensive interaction. And I think as well as kind of, if you like, celebrating the achievements and the coordination achieved, I think it's worth remembering that it does come at a cost as well. And there is this risk of burnout and stress that's coming through some of our findings. So I think that's worth kind of bearing in mind as well. So these are the references I drew on today. And I think, thank you all very much for being here, and I'm very happy to have any kind of reflections from you on the presentation, the talk, and so on. So thank you.
Thanks a lot, Simon. That was really great and very interesting. We have about a bit more than 20 minutes for questions. So if you have a question, please raise your hand. I can see Diana has already done that. So please, Diana, go ahead. Maria, Connie is also raising her hand, so she's going to be next. Diana, go ahead, please.
Thanks, Giorgio, and thanks, Simon, for the presentation. I think this study is super interesting, and not just the paper that you present, but like the whole structure around the project. My question is about, I'm a bit lost about the unit of analysis of your study, and I'm gonna explain you why. And it is because, like, early in the presentation, you mentioned something about focusing on the relationships of the organizations in the system, which I think is very interesting for understanding systemic change. But, and when you start, like, the point of departure for this paper, in which you do some zoom in this paper of the health system leaders, you talk about this narrative about innovation at the system level, right? So, but then you show us this specific paper, which is more about the 31 interviews with health system leaders, and it's more about the way they're making sense of the impacts of the situation in their work. And when I look at the preliminary findings, I think, okay, but those effects are not specific to these people in the health system, because many of the things they're saying, I mean, we have faced pretty much things that are similar to what they're like the way they're making sense of the impacts of the pandemic in their work. So I kind of move from a system level perspective, a narrative of innovation in the system, to then kind of individuals making sense of their workplace. So I kind of lost the unit of analysis there. And I think it is because at first I didn't see, like, what is this major systemic change in the system. So I'm sure you have advanced in understanding this, but it's like, what is it that we change at the system level? Was it that we change the rules of the system? Are Colombians now receiving a different kind of provision from the health system? Or the change was like the way the system is coordinated? Like, I don't have clarity yet. Of course, I understand that the system had to accelerate the pace at which it provides services to the citizens, and also kind of the scope or the number of people that it has to attend in a specific time unit. But I'm not sure about which were those kind of big changes that we're talking about to then study, yeah, I'm kind of lost there into understanding that connection between unit of analysis, the system, the individuals making sense of the change, and then what was this major systemic change. Was that clear?
Yeah, so thank you, Diana. So the first question, unit of analysis, yeah, I did move around a bit. So I didn't want to present the kind of the overall analysis, which is very much around these 6 rules on the screen, because we did a webinar last month on that, and I wanted to do something different today. And the guidance that we've produced from health system leaders So that kind of map of Colombia, I think you can see, and that looks like an ocean. That's on our website, and that's more aimed at health system leaders. So I wanted to give a flavour of that, but then focus much more today on this more recent paper on this idea of resilience. And the reason I presented that is because we got a proposal accepted for a special issue of a journal, and we had to write this paper by last Wednesday. So I thought, okay, I'll present it today as well. So that's why I've looked at this subset of interviews, and I wanted to present that today. And it's partly because I wanted to have a chat about how people feel generally within universities as well, faculty. There's more research coming out about the negative effects of COVID on the whole workforce and everyone else. So I wanted to kind of show those connections. But in terms of broader level kind of unit of analysis, we've written a paper on interorganizational collaboration, which is currently under review. We've written a paper on intersectoral collaboration between the health system, private enterprise and universities, that's under review. We've written a paper on workforce, particularly the kind of psychological effects on the workforce. That's under review, but that's a preprint, so that can be found, I think, on our website. And we've got a chapter coming out as well, which is on that second rule, which is this idea of trial and error learning. So I've just focused on a subset of interviews today, and I think I should give a health warning as well, in that we have done a lot of interviews. We've done 118 interviews, but I've never undertaken a study before where we've tried to understand a whole set of adaptations to health services, so I think, and a snapshot. So most of these interviews were done within a 6-month period last year. I think we're collecting data around November. It was a very difficult time for the health system as well. So people were talking to us while dealing with a lot of difficult things. So and in the paper, we acknowledge this is a snapshot, and we really need to do some follow-up interviews. And perhaps if I was designing another evaluation, this is just a 10-month study, I would probably say, right, we're going to look at some particular services. We're going to zoom in on particular types of services and then compare them. This was much more an exploratory study. And then just in terms of major system change, so this is a concept, and it applies to coordinated forms of change that I've looked at in earlier work in the UK, and there's a bit of an international literature on it as well. And the main point about major system change is that it's not about innovation within a particular hospital, for example, by a single provider. It's about the coordination of different organizations and how they align or don't align their stakeholder interests. So if you like, it raises the bar in terms of innovation, because you're trying to get multiple organizations to work together, which is very challenging, but potentially the prize is much bigger, because when we looked at acute stroke services, we looked at their centralization in London and Greater Manchester. They were trying to improve acute stroke services for a whole metropolitan area. So if they get this right, and there was a lot that suggested they'd implemented a set of changes that improved outcomes for patients, then the whole population of the area benefits. And that's why I'm interested in this kind of coordinated change, because the benefits are much greater rather than one hospital improving services for just one, for their own patients. Others lose out. Why? Why not work together? So that's the kind of idea. And so we use that as a theory. And I think the theory around major system change it's about how do you guide major system change. So that literature talks about change being a social and political process. If you wanted to make major system change, these are some ideas, and the 5 of them I think are on the screen there, that should support should support the accomplishment or implementation of change. And so all we did for this kind of overall study was based on, if you like, the disparate evidence we could collect, this exploratory study, and I admit it's disparate evidence. We came up with these new rules or recommendations for guiding adaptation that we think are more relevant to the kind of processes we saw in response to COVID-19. So major system change is very much about longer term planning. This pandemic was about, if you like, emergency responsive planning, while health systems were really under the cosh. So these are the new rules that we came up with. And and as I said, we didn't look at one change. We looked a bit at ICUs, we looked at telemedicine, we looked at changes to planning, we looked at changes to relationships between entities. And maybe one thing I could do is maybe work a bit more on mapping that a bit more.
That would be very helpful.
Okay. Okay.
Helpful, but
All
thank
right.
you for interesting work.
Okay. Thank you. Thanks for your good thought-provoking question. Thank you.
So next is Connie that raised her hand before the others virtually. She did it in the old way, pre-pandemic way, to call for attention. So please go ahead. Then we have Eduardo, Clemente, and Diana. Connie, go ahead, please. Connie, your microphone is off.
I find it easier to just raise my hand. Yes, pre-COVID and pre-everything. I have more comments than questions for Simon. First of all, I want to congratulate you for the opportunity of the study. I don't know if you remember when we did the interview, when you were being selected, the recruitment interview, and you mentioned that your field of study was health, etc., and you were looking for where to do your applied studies, etc. And here you found this big area, that maybe you weren't expecting. So I find that it's very interesting that you were able to come up with go fast with a study that serves your purposes and your interest and your previous work. Now, I had some comments about this mental health issue. If I understood properly, you said that these psychological conditions that the people interviewed mentioned were there before COVID. So I have qualms about if you provide services, and I studied in the mental health department in the US, and there are several discussions about, or there were several discussions about, if you provide the service, people are going to use it. Now, that doesn't mean that they need it more than before you provided the service. So I have questions about, do people really need all that mental health support, all those psychological support? I'm sure that they need it now, but in regular situations, would they need it? That's something that I find interesting to go in further. And the other thing I had, and that was more of a question, is who are you going to present this to? Because I find it fascinating that you did a study in a situation that's happening right now, and it's not over yet. This is going to continue. So who do we go to with your studies so that this is useful for the people that are living it, that are making the decisions, that are going to provide the resources to continue doing whatever you recommend? Well, that is a question. The others were just comments.
Okay, thank you. Thank you very much, Connie. Yeah, I think with mental health, the idea, I think, is that COVID wasn't just a kind of mirror on how health services were provided, but potentially exacerbated things as well. And I think that from our kind of discussions with the interviewees, there was this idea that there were pre-existing problems. I would talk about the workplace, and and how appropriate the workplace is for people to work in. And it's not just something I've talked about in Colombia. We talk about this in the UK as well. The workforce is a big issue. Generally, working conditions are a big issue, particularly for kind of lesser recognized staff. But I notice here there's talk about doctors as well in Colombia. So my sense is that there were already challenges with working conditions here, and that's something we found in the UK as well. And the spotlight was really turned on those in response to COVID. It kind of raised a light, highlighted problems that were already there, and then exacerbated them. In terms of responses to that, I think I'm not a psychologist, I don't have your expertise, and I think it'd be working with other people. We've collected some examples of how people have been affected, and also some examples of how, for example, hospitals have responded, trying to improve morale and so on. But in terms of linking the problem to then some solutions, I couldn't do that. Secondly, in terms of knowledge mobilization, yeah, it's very important to kind of mobilize the findings from the study. We've got a stakeholder list, so everyone we've interviewed is on that list who we communicate with. We gave an end of study webinar. We've given some local feedback to different sites in the 3 cities, and we've got this guidance that we've produced as well. And I think the danger is that it sits on the web server somewhere and isn't used. And I think that's where there needs to be ongoing work to actually start to share our findings more and have a dialogue about what we found, and start to try to influence things going forward. But it needs a further push. I think the first push was just to get the study done, and then.
Let me just interrupt you for a second. I think one person that would be interested in knowing about this is the rector of our university. He knows about health. He was in the job for a while, and he has all the connections. So he's going to be heard. He needs this type of information.
Yeah.
That's just a suggestion.
Yeah. No, yes, I'm aware of Alejandro. Yeah, but yes, we do need to give it another push.
Thank you. Sorry.
But thank you very much, Connie.
Eduardo, please go ahead. Eduardo, your microphone is, we can't hear you.
Sorry. Well, Simon, thank you very much for your very interesting and timely presentation about this COVID crisis we are suffering at this moment. Well, I have some comments and questions. Your presentation raises a lot of interest in terms of questions for future research. So I wanted to ask you, you speak about a narrative, innovation narrative. So I wanted to know, how are you establishing or measuring innovation in this particular study? So how do you know if what people talk is really an innovation? Is it at the process level, product level, or how are you measuring this idea of innovation? And the second, related to question of research, is which are the personal and organizational circumstances that can lead either to trauma or to solidarity? I think that's very interesting. So if you could specify or understand which are the personal characteristics at the nurse level, doctor level, administrative staff, or organizational variables that can result either in trauma or solidarity. How have you approached that, and which are your ideas to work on that research question? And thank you very much.
Thanks, Eduardo. Some terrific questions there. I'm tempted to say I need to think about them, but in terms of measurement, we haven't measured if you like, the innovations. I think what we're arguing, and if you like, therefore can we call them innovations, right? Which I think is what you're saying. But I think we're saying there needs to be evaluation. So that first point there, I think, needs to be a system-wide audit of what has emerged in response to the pandemic, and some kind of realist analysis. There are some realist questions there for perhaps evaluating innovations qualitatively, which is what works for whom at what cost, which would be a realist evaluation. I would like to say more, but I think one of the challenges is that because the impact of the pandemic has been so pervasive, there have been responses at different levels to it. There does need to be some kind of audit of what's changed. And I think through our particular study, we haven't measured that. It's been an exploratory study over 10 months. And I think some follow-up work focusing on some innovations, maybe categorized into different types, would be really useful, and thinking about what are the useful kind of criteria for evaluating them. But I think that would need to be some follow-up work that's very, very important to do. I don't think we should be kind of attracted by this kind of seductive word of innovation. I think we need to kind of call it service change, and then quite agnostically determine what changed for whom, who were the winners and losers, if you like, from this change. In terms of linking kind of organizational conditions to whether you get trauma or solidarity, I think we haven't really done that, and I think that's a very important piece of work to do. I think part of it would be helpful to do some international comparative work, and maybe comparing different starting conditions across countries, and then what kind of effect that had on responses. We seem to have seen difficulties in many parts of the world, even within presumably quite resilient health systems, to the pandemic. But again, I think that would be a great piece of further work to do. Further research on that is definitely needed, and we haven't really looked at that at all yet. Quite exploratory stuff.
Okay.
So,
Thank you very much. Thank
Thanks.
you very much, Simon.
Thanks, Eduardo.
Thank you. Clemente raised his hand before. I don't know if Clemente, if you still have a question that you would like to share. I'm not sure if Clemente is there. Maybe not. So maybe I'll use the 2 minutes that we have left to also ask you a question, Simon. I was thinking that a lot of what you described is related to acceptance. So you talk about innovation, you talk about acceleration, about disruption. And when you read the interviews and when you think about the situation in which everyone has been in, including ourselves at the school or at the university, a lot of this innovation has become possible now because people accepted the change. The need, as you said, was there before. People knew that a lot of these things had to happen at some time, but there was a lot of resistance, sometimes maybe because you don't feel like it, maybe sometimes you are afraid of it, and so on. So I was wondering whether, and this, as you said, comes with a cost in terms of stress. People become stressful. And I was wondering two things. One, if you think, based on maybe your previous studies, whether there is an effect of the organizational structure on this cost. If flat organizations are, they create less resistance, less stress than more hierarchical one, as one of the interviewed people said, I think. And the second question will be if you can think of any other system of incentives that could be monetary or non-monetary incentives that may, in times where there is no crisis, where they could still beat this resistance and this fear.
Thanks, Giorgio, for your questions. Really good questions again. I think I'll start with the second one first. So the system of incentives. I'm going to be a bit of a social scientist answering these rather than a kind of management faculty member. But one of the problems with the diffusion of innovation literature is that it assumes that, if you like, resistance is a bad thing almost. So there's this set of innovations that should be adopted. Why aren't people adopting them? Why do we have kind of laggards? And so resistance is almost there to be overcome. And I think that there's something around kind of democratic decision making here. So I think you incentivize people by co-producing innovations and having a dialogue about them from the outset. And that also comes from the major system change literature. You should engage a variety of stakeholders, not just physicians, also patients and families, and make sure that stakeholder engagement informs where we're going with health services, where we're going with particular changes to whatever service, maybe patients rely on. So I think that's what I would kind of focus on, kind of how do we improve co-production, and is there a danger that that hasn't happened as much because there's been these very quick decisions made almost by necessity, but how good has co-production been and who's been involved in those conversations? Is it the very powerful medics, for example, who again have dominated decision making? And I can't give a definitive answer to that, but I think an incentive is having quite democratic decision making. That's what I would focus on. And then in terms of structure, I guess, yeah, flat versus hierarchy. Professional hierarchy and status is very strong in health systems. I've looked at postal services, broadcasting, as other public services. Professional hierarchy is much, much stronger in healthcare. You have a lot of very kind of highly qualified people with big egos and their own specialties. And so it's very difficult to get them all to agree and work together. But I think that there are some messages coming out about, well, how can we address hierarchy within and among professions? How can we involve not just doctors, but nurses, other auxiliary staff, allied healthcare professionals, and make sure we have that dialogue. So again, I think making decision-making more open and democratic on the one hand, and then ensuring that evidence flows into those kind of decision-making processes that represent those different stakeholder perspectives. So I think a lot of stakeholder mapping and thinking about shared priorities and ways of making decisions more democratically, I think is important. But I think I haven't maybe said enough there, but that's
no, this was,
ask some
was
interesting
a great
questions.
Answer.
Yeah. Okay.
Thank you, Simon. Do you have 5 more minutes? Clemente is back with his hand raised, so if you have...
Yeah, sure.
So maybe, Clemente, please go ahead, please.
Yes, thank you. Thank you. I got lost for a while, so I'm going to ask you a question, Simon. Well, I am interested in health institutions and how they have evolved during the pandemics. So I'm going to make 3 observations about these institutions, and I would like to know your reaction about that. Well, first of all, I want to congratulate you what Connie and Eduardo have said about your work. I believe they are very right. Now, a couple of days ago, I heard an intensive care unit doctor speak about the priority rules for admitting patients to these intensive care units. And it was extremely interesting. It seems to me that there has been an evolution in those rules caused by the pandemics. And in the triage system of hospitals, I went to look into those rules. There are some international guidelines, and there are some references to those rules in a law of 1915 in Colombia. But it seems to me that those rules have been changing during the pandemic. So that's the first point. The second institutional point is that I found I was an evaluator of many projects related to the pandemics a few months ago, and I was not an evaluator of your project, let me tell you. But I found that in many of those experiments that were designed, the number of observations was very low, very low. Sometimes they talked about, finding results with 25 studies, 25 cases. With 8 cases, you know that with 8 cases, some big decisions have been made during the pandemics, and this is very low compared to what we do in the social sciences. So this is and I believe it's a custom. It's something that is rooted in the minds of the researchers in the health field now. And the third observation is that one of the lessons of the pandemics is that we need a lot of science and we need a lot of industry in a country like ours to be relatively autonomous, independent, and sufficient to deal with these kind of crises. Now, what I find is that the political system is not at all conscious about the importance of science and of industry. And I think that that lack of change, that lack of reaction on the part of the government deserves some thinking, some institutional thinking, because this is a case where you have a great disruption, but no reaction on the part of government on thinking a lot more about the long run. Those are the 3 comments, Simon.
Thank you very much, Clemente, for your really insightful remarks as usual. Really good comments there. In terms of kind of the evolution of health institutions, and I guess rewriting and adapting rules and so on, including triage. One thing that we came across was, this was one of our kind of our earliest output, which was a chapter for an international collection that's coming out in the summer on the need for trial and error learning. So this acknowledgement of trial and error learning was talked about by some of the people we spoke to in terms of health service planning. So recognizing that the context was one of uncertainty, the evidence was emerging, it hadn't really solidified yet, it still hasn't solidified into a solid base, and therefore there might be some need for trial and error learning, which is unusual in healthcare, I think, or in thinking about core services where patient care and triage obviously goes to the core of that, where patient care and safety is very, very important. So it is very unusual to see that. And there's this adage that it takes 17 years for an innovation to get from the bench laboratory through to the bedside. And people moan at this, but one of the reasons for that is because of patient safety. And you need to be very sure when you're working with bodies, with people, that you're intervening and you don't do any harm. So that's why that systematic approach to evaluating evidence is very strong I think in health systems as an industry, comparing it with other industries, have very rigorous processes for that. And there has been some kind of change around experimenting more and use of trial and error learning. And one of the things I liked was that they talked about, well, can we hear from different experiences, opinions? Can we get a whole group of people into a room together in order to debate this emerging evidence? What's meaningful here? And I think that's a positive move, but there still needs to be some standards around decision making and how do you judge the validity of evidence if you've got this slightly more relaxed approach because of particular circumstances. But I think there is something to learn a little bit about trial and error learning possibly in the future and its value in some types of decisions. In terms of, I guess, evaluation and sample sizes and so on, we've just had this systematic review accepted in implementation science of responses to the pandemic at different levels, kind of organizational responses. As you know, there's a massive literature out there. There's a massive evidence out there. And a lot of it's on kind of preprint servers as well at the moment. So it hasn't been through full peer review. But what we actually found was we found 34 studies that were relevant over the past year. And we only included 25 of those in our systematic review. 9 of them were excluded on quality grounds in terms of the quality of the methods used. There were 3 studies that were really potentially useful with health system leaders from the UK, Spain, Italy, and the US. And they were very early kind of experiences, but they didn't do enough with the findings to get into our review. And if they could have gone a bit further. So I think there's been this tension between kind of timeliness of evidence and the robustness of evidence that's been that's been going on over the past year. But I was quite surprised we didn't find more robust studies, but that paper will be coming out shortly. But it's something about producing evidence in response to a pandemic or crisis. And then finally, science and industry. We've written a paper on intersectoral collaboration. I think it's our 6th rule, which comes from intersectoral collaboration, which talks very much about building collaborative structures between industry, health systems, and universities, and how the 3 can work together more effectively. I think there was quite a lot of what I would call more informal interaction between those sectors, relying on, if you like, informal networks between them. And I wonder whether there's opportunity to create more collaborative institutions that help to bring those 3 sectors together around, for example, defining and producing evidence around particular health system priorities. So it's something we've got in the UK. We've got what we call collaborations for applied health research centres. There are 13 in England in different regions. So there's one for North London. And there are, in the collaboration I used to work for in UCL, we had 48 partners, 5 universities, and then these partners from the health system all working together. And I think if those types of collaborative structures were a bit more established, and people were used to working with each other, having a shared language across these sectoral boundaries, working out what motivated each sector and their priorities, what they can give as well when there's a common problem to face. I think if those relationships are already established, they'll be more agile and able to respond when they're really needed. But I think they're also needed, if you like, in the everyday as well, in terms of robust, resilient health systems. So I think investment in science and technology and bringing those different sectors together in some kind of collaborative structure is really, really important for the future. Okay, thank you.
Thank you. Thank you so much, Simon. I think because of time we have to stop here, but it was extremely interesting. I think your as the others said, your work has great potential for a big impact locally and also internationally. So I congratulate you for this, and I thank you for accepting our invitation and for this very nice talk. And I thank also all the participants for their assistance and for their nice and interesting questions and comments. We'll see you in a couple of weeks for the next seminar. Thank you all.
Thank you, Giorgio. Thank you, everyone.
Have a nice weekend. Bye-bye. Thank you.
Ciao. Gracias. Bye-bye.
Bye. Thank you.